Welcome to Dr. Sam's anatomy classes. Here we are exploring the intricacies of human body. This is a question paper of anatomy from Rajshree Medical Research Institute, Bareilly, of third internal assessment of first professional exam for the students admitted in MBBS 2020 batch. So this question paper was of 100 marks and it has 3 sections. This was section A of 20 marks, which was of 20 MCQs, 1 mark each. And then it was section B. This was of 40 marks. This was subjective with long and short questions. And similarly, then again, there was section C according to the university norms. So that makes up 20, 40 and 40. That's 100 mark question paper. B and C are all subjective. So we will be going through these questions from B and C section later on. Right now, we're going to solve these 20 MCQ. So let's begin with question number 1. Which structure lies in lateral relation to the left ureter? Choices are inferior mesenteric vein, inferior mesenteric artery, left testicular artery, left testicular vein. So let's presume that this is the left kidney and this is the left ureter. Then here what I've drawn is the abdominal aorta. The abdominal aorta gives these ventral visceral splachnopleuric branches which are unpaired. This one is celiac trunk that arises from the lower border of T12 vertebrae, and then it's superior mesenteric artery that arises at the level of L1 vertebrae, and this is inferior mesenteric artery. It arises at the level of L3 vertebrae. So this inferior mesenteric artery will descend down like this because it's going to supply the structures derived from the hindgut. So it has a left lateral course, reaches towards the apex of this sigmoid mesocolon and continues down as the superior rectal artery. The next structure which will be in relation to the left ureter will be the left inferior mesenteric vein. Now this inferior mesenteric vein, it joins this splenic vein, and this one is inferior mesenteric vein, and splenic vein joins the superior mesenteric vein from the portal vein. The next structure again that will be in medial relation will be the gonadal vein. This gonadal vein from the left side, the left testicular or the left ovarian vein, this also will be in medial relation to the left ureter, and that it is the renal vein. This left testicular vein or the left ovarian vein, it joins the left renal vein, and this structure is left gonadal vein, which may be testicular or ovarian. Now from the abdominal aorta at the level of L2 vertebrae, these are the ventral lateral splachnopleuric branches which supplies the structures derived from the intermediate mesoderm that includes components of the urogenital system. Now this gonadal vessel will actually cross these structures and will descend on the lateral side of the left ureter. So this will be left testicular artery in case of males or left ovarian artery in case of females. So remember, these are the relations which are important for your theory exams as well. Answer here is left testicular artery. Now question number 2 is coverings of medial direct inguinal hernia are all except extraperitoneal tissues, fascia transversalis, cremastric fascia, external spermatic fascia. You have to rule out which one is not a covering of the hernial sac descending down through the medial portion of the Hasselbach's triangle. Now let's understand the concept of inguinal hernia. These are the inguinal ligaments, and here it's the deep inguinal ring. It's this triangular opening, the superficial inguinal ring. This is the inguinal canal. It's like this, the inguinal canal. So if a viscera protrudes, passes through this opening and continues passing through the inguinal canal and then emerges out like this through the superficial inguinal ring, then such an hernia is called an indirect inguinal hernia. On the other side, I'm going to show you is what is direct inguinal hernia. So direct inguinal hernia is simply passing through this directly through the superficial inguinal ring. In this case, the hernial sac passes directly through this superficial inguinal ring. So this hernia is direct inguinal hernia. In the same diagram, I should include one more thing, and that is about the femoral hernia. Here it's the femoral sheath. The medial most compartment we say is the femoral canal. So if a hernia passes directly down here, passing out through this femoral ring, the femoral canal, and reaches down to the thigh, this hernia is called femoral hernia. So how to differentiate it clinically if a person is complaining of like a bulging or protrusion in the inguinal region, lateral or medial to the pubic tubercle on cuffing or straining. So one easiest point is you have to palpate upon the pubic tubercle. So pubic tubercle you will find here that is placed here. This is pubic tubercle. Remember that femoral hernia which you can palpate lateral to pubic tubercle and direct or indirect, both of them, this will be palpated medial to the pubic tubercle. Now, talking about this direct inguinal hernia, because direct inguinal hernia have been subdivided into medial and lateral types. If that's what is your question about, let's draw here in detail. This you are considering as the let's draw only one side. This is pubic tubercle, pubic crest, pubic symphysis. This is the iliac crest, right? And anterior superior spine, and this is inguinal ligament. So here what you'll find is this muscle here with bifided heads of origin, and this is called rectus abdominis of one side. So this muscle is rectus abdominis. Just about 1.2 centimeter above to the midpoint of inguinal ligament, you find is an oval opening, and that is called the deep inguinal ring. That's an opening in the fascia transversalis. And just medial to that, from this artery running down here is external iliac artery. So from this external iliac artery, there's a branch that runs towards this anterior superior spine and along the iliac crest. So this is the deep circumflex iliac artery. There's another branch which arises from it medially and runs towards this umbilicus. Now this artery is called the inferior epigastric artery. Don't confuse the superficial inferior epigastric, because superficial inferior epigastric is a branch from femoral artery, and that's a content of fascia of Camper. Now there's a triangle formed. So this triangle formed here is called the Hasselbach's triangle. This triangle is further subdivided by the medial umbilical ligament. It runs like this here. This is medial umbilical ligament. Now what is this medial umbilical ligament? It actually is a remnant of the obliterated umbilical artery. Now as you know, the hernial sac will have different layers. Let's say we're talking about hernial sac. So one thing is the peritoneum, of course, carrying the loops of the intestine. And outside to peritoneum, what will be there? There will be extraperitoneal connective tissue. The yellow color, extraperitoneal connective tissue. And the black one which I had drawn was peritoneum. And then what lies anterior to this is fascia transversalis. The hernia can pass out through this also, or the hernia can pass out from this opening as well. So if this is the lateral, this is called the lateral direct inguinal hernia, and this is the medial direct inguinal hernia. So your question, I think question was asking about the medial direct inguinal hernia. Now because fascia transversalis, we are counting these layers from deeper to outside. So after fascia transversalis, you will find is the muscles of the anterolateral abdominal wall. So you know that the transversus abdominis and the internal oblique abdominis Both of them actually, they are forming the anterolateral wall, then the roof, and those muscle fibers, they actually join and they form a roof like this. These are the fibers of internal oblique abdominis as well as the transversus abdominis. So these fibers actually, they form a tendon here. This is called the conjoint tendon. Conjoint tendon. And this is going to form the cremastric fascia. And you also know that here you're going to find is the superficial inguinal ring. From there, this spermatic cord going to descend down along with the testis. So this cremastric fascia continues down into the scrotum, forming one of the layers of the scrotum. But this conjoint tendon is placed here medially. So this layer I have drawn is in dotted line. So you understand that this is cremastric fascia. This you will find in this one. And this hernia, the B1 hernia, which is passing medially. Now in this case, this layer will be made up of conjoint tendon. This will be present in the B sac and this will be present in the A sac. This is the variation, the difference in the sac of direct inguinal hernia, medial and the lateral one. Or you can say the lateral direct inguinal hernia, and this one is in the medial direct inguinal hernia. And of course, when it emerges out, you will find is the external cremastric fascia. Now this external cremastric fascia here, this layer on outside, this layer is external cremastric fascia. Now external cremastric fascia is actually the continuation of the aponeurosis of external oblique abdominis, which even is present in the scrotum. And of course, the last of all will be the skin. So these are the layers of the, you can write it down, layers of direct inguinal hernia. In this image, the additional point, the lateral direct inguinal hernia, you will have a cremastric fascia. Only difference is that in the medial direct inguinal hernia, instead of cremastric fascia, you will have as a conjoint tendon. I hope you've understood this. Now let's move back to the question. Question number 2 was, coverings of medial direct inguinal hernia are all except extraperitoneal tissue. We had seen there was there, fascia transversalis was there, external cremastric fascia was there. Cremastric fascia you're talking is about the medial direct inguinal hernia, right? So you know that instead of cremastric fascia, there should be a conjoint tendon. So the answer here is also C. Now question number 3 is, contents of triangle of Marcille are all except lumbosacral trunk, obturator nerve, sympathetic chain, femoral nerve. Now to understand the triangle of Marcille, you need to know about the sacrum. Let's presume this is S1 vertebrae, and here you know it's the ala of sacrum, both the sides. Then you have is sacrum is like this. Down below it will be the coccyx, and here you find is the intervertebral spaces and the pelvic sacral foramina. So you have S1, S2, S3, S4 and S5 vertebrae. They have fused to form the sacrum. Now you know that this muscle, psoas major, it arises from all these lumbar vertebrae, from the transverse processes of all the lumbar vertebrae, as well as from the adjacent surfaces, the lateral surfaces of the body of these vertebrae, the arcuate ligaments attached to the body of these vertebrae on the sides. This is psoas major descending down, and we have focused about the origin of psoas major. This is how it descends down below the inguinal ligament and gets attached to the lesser trochanter of femur. Now talking about what is triangle of Marcille, this is actually the triangle of Marcille we're talking about. The boundaries of this triangle of Marcille, one is on the medial side, it is the body of L5 vertebrae, and laterally it is the medial border of psoas major muscle. This is psoas major. The base is formed by the ala of the sacrum, and the apex of the triangle is formed between the origin of psoas major from L5 transverse process as well as the body of L5 vertebrae. So that's the triangle of Marcille. Now the question is about the contents or the structures passing through this triangle. I hope you know the mnemonic, which will make it easy for you to remember. The mnemonic here is oils. Remember, OILS. It's from lateral to medial. So here it will be OILS like this, from lateral to medial. So the lateralmost structure emerging out from this triangle of Marcille is obturator nerve. Then there will be an artery emerging out, and that is iliolumbar artery. Sacral plexus is formed by the lumbosacral trunk. So there, descending down here is the lumbosacral trunk. This will participate in the formation of the lumbosacral plexus, lumbosacral trunk. And the medialmost, is the sympathetic chain. The sympathetic chain has a beaded ganglion at the level of each of these vertebrae, and it descends down at the level of coccyx from both the sides. It's like this, and down below it forms this ganglion impar in front of the coccyx. This one is sympathetic trunk or sympathetic chain. So I hope you've understood about this triangle of Marcille. Now we back to the question. Contents of triangle of Marcille are all except lumbosacral trunk was there, obturator nerve, sympathetic chain. So the answer will be femoral nerve. This is not a content of triangle of Marcille. Question number 4 is wrong about intestine. Pear's patches are largest and most numerous in the ileum. Brunner's glands lie in the submucosa of the duodenum. Vasa recta are longer in ileum. Orbach's plexus lies between circular and longitudinal muscle coats, which is a wrong statement. This question is actually about the microanatomy of the small intestine. So for that, you need to draw a image, cut section. What I am trying to draw here is for you. Let's say this is a loop of intestine. Longitudinal section of a loop of intestine. Here you will find is the transverse rigid fixed mucosal folds. These transverse mucosal folds will diminish in size and density as we move from proximal to distal, and these transverse mucosal folds of the intestine, they are called plica circularis, also called as walls of Kerckering. So in the question, what was being asked was about the lymphoid aggregates. So throughout the length of the small intestine, you will find is these solitary lymphoid patches, lymph nodules. These are spread throughout. So let's name these as solitary lymphoid follicles. But at certain places, especially, let me tell you that towards the distal portion of the small intestine, there will be large oval-shaped patches, and the longitudinal axis of these patches will be along the length of the small intestine, right? And these patches will diminish when we are talking about the proximal portion of the small intestine. So these large patches, which are actually aggregates or aggregated lymphoid follicles, which are actually called Pear's patches, they are more predominantly or more densely found in the ileum. These are the features of ileum, except the duodenum, which is a fixed portion of the small intestine, but jejunum and ileum, right? The jejunum and ileum, they are covered by this mesentery like this. This is a mesentery which encloses this length of the small intestine like this. This is the mesentery through which this loop of intestine is suspended, and in its root there will be this superior mesenteric artery, superior mesenteric vein. So from this superior mesenteric artery, which is running along its base like this is superior mesenteric artery running in its base of the mesentery. It will send out small little branches here, around 15 to 20 on the left side, because the mesentery is suspended from this root of mesentery towards the left, and from these there will be branches, and then these branches will anastomose and will form arcades like this. So these arcades, you will find that they are more predominantly found here in the distal portion of the intestine. These are meshwork of the blood capillaries. The arteries actually ramify, they divide and redivide, and they form this arcade like this within the mesentery. Now what happens is, from these arcades towards the mesenteric border of the small intestine, there will be now vertically or straight vessels reaching up to the small intestine alternately on the two sides like this. One will reach from the opposite side to reach towards this, this border is called the anti-mesenteric border, and this border is called the mesenteric border. So from this mesenteric border, alternately, the straight vessels, they reach, in the submucosa. They will, of course, first of all, they will perforate those outer layer, the muscular layer, and then will reach into the submucosa. And within the submucosa, they will run transversely and will reach towards the anti-mesenteric border. So these straight running vessels, they are called vasa recta. Small vessels providing blood to this loops of intestine, these vessels are called vasa recta. Now, as you have seen, let's say this is the proximal portion of the intestine and this is the distal portion of the intestine. So what you're seeing here, that the arcades are only 1 to 2 in layers, 1 or 2 level of arcades, but here the arcades are 3 to 4 level of arcades, means you have more of arcade formation in the distal portion of the small intestine. Now from those arcades, there were the straight vessels reaching to the small intestine, and those were called vasa recta. So vasa recta, in this proximal portion of the small intestine, you are seeing these are long, and in the distal portion these are short. And talking about transverse section, in the proximal portion of the small intestine, you will find that the villi which are projecting out from the luminal surface of the mucosa, they are long and densely placed. But as you move towards the distal portion of the small intestine, you will find that the villi will be shorter in length and the density also keeps on decreasing. And what is invaginating inside are the crypts of Lieberkühn. So these are villi, intestinal villi, and these are the crypts of Lieberkühn. Then this much will be the lamina propria. Then there will be submucosa, and below the submucosa you will find is the muscular layer. Inner will be the circular muscle layer, outer muscular coat is the longitudinal muscular layer. And because it's a peritoneal covered organ, so outermost surface will be made up of serosa. Serosa means it is a cellular covering which is made up of mesothelial cells. Simple squamous epithelium surrounds this small intestine, and that is called serosa. Circular muscle layer, and this one is longitudinal muscular layer. In between the two layers, between the circular and longitudinal muscle layer, you will find is nerve plexus. This is a part of enteric nervous system, and this nerve plexus is called orbex plexus or Meintrick. There is a plexus here also in the submucosa called Meissner's plexus. Remember these neurons, the autonomic neurons, sympathetic and parasympathetic fibers, when they reach to innervate the muscles of the gut, because autonomic fibers, they innervate the smooth muscles. So there will be international neurons, and there will be special neurotransmitters like VIP, vasoactive intestinal peptides. You will have special cells there, and those are called interstitial cells of Kajal. So they also participate in this, and that's how this coordination between the circular and longitudinal muscle layers that take place. Yeah, one more thing which was in question was about this Brunner's glands. These are the glands opening here in these crypts, and these Brunner's glands are actually placed here in the submucosa. This is example of actually compound tubuloacinar glands. So in cut section you will find them here like this in the submucosa. But remember that these Brunner's glands is a feature of duodenum. Once again, back to the same question, wrong about the intestine. Pear's patch is the largest and most numerous in the ileum. You have seen this. Brunner's glands line the submucous of the duodenum. I had shown you there. Vasa recta longer in ileum. Orblex plexus lies between circular and longitudinal muscle cords. And this one is vasa recta, they are longer and more densely placed in the jejunum and they're smaller in the ileum. Question number 5 is wrong statement about the branches of abdominal aorta. Celiac trunk arises opposite to the lower border of T12 vertebrae. Superior mesenteric artery arises opposite to L1 vertebrae. Inferior mesenteric artery arises opposite to L3 vertebrae. Gonadal arteries arises opposite to L3 vertebrae. So again you have to find out the wrong statement here. Presume it the vertebrae T12, L1, L2, L3, L4, L5. You know that abdominal aorta descends from the aortic opening in the diaphragm and it descends down in the median plane like this. But down below it has slightly an oblique course. This slight oblique course makes it tilted slightly towards the left side 1.5 centimeter from the median plane. Just below to the diaphragm, ventral splantanopleuric branches. So from the junction of T12 and L1, there is this one unpaired branch that arises here and that is called celiac trunk. Then from L1 also there's an artery branch arising and L3 also arising. So keep learning with this. This is celiac trunk. Then you have a superior mesenteric artery and this is inferior mesenteric artery. Then there are branches arising which are ventrolateral splantanopleuric branches which is supplying the structures derived from the intermediate mesoderm, and as soon as it emerges out it gives a branch on the undersurface of the diaphragm, that is inferior phrenic artery, middle phrenic arteries at the same level as the celiac trunk. The renal arteries, remember these are very important. This is asked many times. Renal arteries arising at the level of the transpyloric plane, that is between L1 L2. And then there are two branches which arise from the level of L2 vertebrae, and these are the gonadal branches. So I hope you understood the vertebral levels also. Why not include some other branches here? Remember that inferior phrenic artery gives this branch here. This is called superior suprarenal artery, and this renal artery also gives branch from here, and these are called the inferior suprarenal arteries. Remember that suprarenal gland is so much vascular, it has three blood supply from three different sources, although it has a single vein. So keep noting down the vertebral levels. Gonadal arteries you can see as arising from the level of L2 vertebrae. Inferior mesenteric artery is arising at the level of L3 vertebrae. Superior mesenteric artery you are seeing it is arising at the level of L1. Celiac trunk you can see is arising at the lower border of T12 vertebrae. And don't forget that the abdominal aorta terminates or divides into two terminal branches at the level of lower border of L4. Wrong statement of the branches of abdominal aorta. You have seen celiac trunk arises opposite to the lower border of T12 vertebrae. Superior mesenteric arises opposite to L1 vertebrae. Inferior mesenteric artery arises opposite to L3 vertebrae. Gonadal arteries arise opposite to L3 vertebrae. You can say that this is a wrong answer. Why? Because gonadal arteries arise opposite to L2 vertebrae. Question number 6. Referred pain of cholecystitis to the inferior angle of the right scapula is through vagus nerve, phrenic nerve, greater splanchnic nerve, or it's by mechanical pressure. Here is the location of liver. Down below, somewhere here, the cystic notch you find is the fundus of gallbladder protruding out, and this actually is the level of the tip of the ninth costal cartilage. Remember that. Now, this referred pain can reach to different directions. One, it can reach in the epigastric region in case of cholecystitis. So, the referred pain can reach there at this inferior angle of the scapula, or it can also reach to the right shoulder, summit of shoulder, the three sides, very commonly asked question. Now if you're talking is about the referred pain here in the epigastric region, remember this, for this you need to know about the nerve supply of gallbladder. Now the gallbladder is actually supplied by celiac plexus, then fibers from celiac plexus reach to the hepatic plexus, and from hepatic plexus the fibers will reach to the cystic plexus. This plexus has fibers, all type of fibers, sensory fibers, sympathetic and parasympathetic. Parasympathetic, is through the vagus, both right and left vagus, but right vagus is predominant participating in this. Then sympathetic is through the greatest splanchnic nerves. Greatest splanchnic nerve is T5, T6, T7, T8, T9. Those segments from the sympathetic outflow will participate, and the right phrenic nerve also will participate there. If the pain is being transmitted through the vagus, remember, then pain will be here in the epigastric region, and this will be referred via vagus. If talking about pain referred here in this inferior, in the region of inferior angle of the scapula, and this is the region of seventh rib or the seventh intercostal space. So here it will be through the greater splanchnic nerve. Pain from this gallbladder is being referred to the sympathetic fibers lateral horn of this seventh spinal segment. So that's why the pain from the seventh spinal segment is being referred to the somatic nerves which are innervating the skin here at the right scapular inferior angle. If the pain is being transmitted here to the right shoulder, then it's being referred to the phrenic nerve, because phrenic nerve is nerve arising from the cervical and brachial plexus, that is C3, C4, C5, because the dermatome of the summit of shoulder is by C4 segment. So that means if there is involvement, if this pain of cholecystitis is referred by phrenic nerve, then it will reach to the summit of the right shoulder. And another important point, in case if it's asked, this point here, the tip of ninth costal cartilage. So if you press upon this point here, which actually down below is the fundus of the gallbladder, so there will be wincing pain and the grimace seen on the face of the subject if you press deep upon here. So because the fundus of gallbladder, the inflamed fundus of the gallbladder, so that sign, the tenderness that felt by the subject is called Murphy's sign. Okay, so the pain of cholecystitis to the inferior angle of the right scapula is through greater splanchnic nerves. Question number 7 is boundaries of Callet's triangle are all except. It's an easy question. Choices are cystic duct, cystic artery, lower border of segment 5 of liver, and common hepatic duct. In this question, you need to know nothing but the Callet's triangle. So if this is liver, gallbladder placed here within the gallbladder fossa like this gallbladder with the Hartmann's pouch here, and this is the cystic duct, and the cystic duct it opens into this hepatic duct, which is formed by the union of right and left hepatic ducts, that is common hepatic duct. So you should know that is the left hepatic duct, this is the right hepatic duct, this is the common hepatic duct, this is the cystic duct, and this is the common bile duct. This area here, it is the segment 5. This is the segment 5 of the liver. So the triangle formed here is, this triangle is called the Callet's triangle. Talking about the arterial supply here, this is the hepatic artery proper, which gives its left and right hepatic branches. So from a branch from the right hepatic artery, which supplies the blood to the gallbladder. Now this is called cystic artery. So cystic artery is actually a content of the Callet's triangle. Although there is one more content of this triangle here, and that is called cystic lymph node, also called lymph node of Lund, L-U-N-D. So by now you must have understood now the boundaries of Calip's triangle are all except cystic duct, lower border segment of 5 of liver and common hepatic duct. So cystic artery is not a boundary, it's a content. So answer will be B. Question number 8. Wrong about the lymphatic drainage of intestine. Tubercular ulcers or horizontal ulcers, typhoid ulcers or longitudinal ulcers, solitary lymphatic follicles are distributed throughout the small and large intestine. Brunner's glands are predominantly found in the ileum. Now, this again is a question about the microanatomy of the small intestine. So, we're back with the same diagram here. This is you seeing is a cut section of a small intestine. Towards the distal end of this, small intestine, you find is large oval lymphoid aggregates, and their longitudinal axis is along the length of the intestine. These are called Peyer's patches. This is a feature of ileum. In case of typhoid, Salmonella typhi that invades these Peyer's patches. So because of involvement of these Peyer's patches, there is ulcerations, and later on that those ulcers will spread along the longitudinal length of the intestine. So this is how, because of the longitudinal arrangement of these Peyer's patches, these ulcers are longitudinal ulcers. Later on, what happens, healing and scarring, these will of course will shrink, but they will not actually lead to obstruction of this lumen of the intestine. Now look the other way. Just like I told you about the arterial supply, the lymphatic drainage is also the same way, like from mesenteric border, then along this transversely, these lymphatics, they run along the transversely along this circumferential submucosal coat of the small intestine, and then they reach down into the mesentery like this. So these are the lymphatics draining the loops of the small intestine like this. So in case of Mycobacterium tuberculosis, that infection that lodges here in this lymphatics. So Mycobacterium tuberculosis peculiarly damages these lymphatics. This lodges inside these lymphatics. When it lodges here, it damages. So what happens again? There are ulcers formed. Now these are transverse ulcers. These transverse ulcers are seen in case of Mycobacterium tuberculosis, or you can say tuberculosis. And it's not the lymphoid aggregates, it's the lymphatics that are involved in tuberculosis. Now another thing is, because of healing, later on healing, there will be contractions or the scarring tissue which actually shrinks, and that leads to, because this is a transverse ulcer, right? So when it shrinks after healing, it can lead to obstruction. Another thing I already told you before, that there are solitary lymphoid follicles scattered throughout the length of small as well as the large intestine. Even in the appendix also, you find these solitary lymphoid follicles. These are present in both small intestine and large intestine. Now regarding Brunner's gland, I already told you that in the duodenum you find is these large villous processes, finger-like projecting processes, and what is invaginating inside is the crypts of Lieberkühn. This is how you find is the lumen of the duodenum. Then there is lamina propria, submucosa, and then you have is the muscular layer, inner circular, outer longitudinal muscular layer, and then outermost will be the serosa. Don't forget what I told you about this. Brunner's glands, these are compound tubuloacinar glands found in the submucosa of the duodenum. On cut section you will find like this. These are acini. They are mucus glands. So they will have a basal nucleus, a flattened nucleus at the base, and they will not take good stain because they are not secreting zymogens. The secreting mucin. Mucin is a neutral substance, so it doesn't take good stain. So remember now this point, that Brunner's gland, these are seen in the submucosa of duodenum, and these are compound tubuloacinar glands, and they do not take good stain. So they're pale colored. And more thing is, these are mucus glands. So have you understood this question number 8? Wrong of the lymphatic drainage of the intestine, tubercle ulcers or horizontal ulcers. It's a correct choice. Typhoid ulcers are longitudinal ulcers. Correct. Solitary lymphoid follicles are distributed throughout the length of the small and large intestine is correct. Brunner's glands are predominantly found in the ileum. No, this is found in the duodenum. So the answer is D. Question number 9, need not to explain much about this. Remember that superior vesicular artery supplies blood to all except. So it supplies the pelvic portion of the ureter. It supplies the upper part of the urinary bladder. It supplies the vast difference through its branch that is called artery to ductus deferens. However, urethra, is a perineal organ. This is found below to the pelvic diaphragm. It's a part of perineum. So this is being supplied by the branches from the internal pudendal artery. So remember, urethra is not supplied by superior vesicular artery. So the answer is urethra. Question number 10 is, which muscle has its origin above and insertion below? Choices are external oblique abdominis, internal oblique abdominis, transversus abdominis, quadratus lumborum. Now to understand this, you simply need to understand the attachments on the iliac crest. This is how you find iliac crest from its superior view. The right iliac crest, so this is anterior, this is posterior, and this is the lateral view, and this is the medial view. At this point here, anterior superior iliac spine, there is a ligament attached, and that is called inguinal ligament. Then outer surface, there is a fascia attached here, and this fascia is called gluteal fascia. And on the inner lip, there is a fascia attached, and this fascia is called fascia iliaca. On this outer border, 5 centimeter above to the ASIS, you find is a tubercle, and this is called iliac tubercle. Now there's a muscle attached from ASIS. This is actually sartorius. There's a muscle that takes origin from ASIS, outer lip of the iliac crest up till the iliac tubercle. This muscle is called tensor fasciae lata. And there's a muscle, this anterior 2/3 of the iliac crest. There's a muscle that inserts onto the iliac crest on its outer surface like this. This muscle is external oblique abdominis. Then in its floor, anterior 2/3, there is a muscle that takes origin from here, and this muscle is internal oblique abdominis. The inner portion of this iliac crest in the anterior 2/3, this muscle that takes origin is transversus abdominis. Similarly, posterior portion, then outer surface, there's this origin of muscle called latissimus dorsi. And on the inner surface of this iliac crest, here there is origin of muscle called quadratus lumborum. And on outer surface, the posterior most portion of the iliac crest, including this point here, posterior superior iliac spine, this muscle that takes origin is gluteus maximus, the largest muscle of the human body. And on the inner surface, it will be adjoining the spine. This is erector spinae. For you to remember them, let me name them fast. This is tensor fasciae lati. This is sartorius. This blue color one is external oblique abdominis. The middle one is internal oblique abdominis. Innermost one is transversus abdominis. This is latissimus dorsi. This is quadratus lumborum. And this is gluteus maximus. And this one is erector spinae. This is posterior superior iliac spine. So remember, what arises from posterior superior iliac spine is gluteus maximus. From anterior superior iliac spine is sartorius, and there is attachment of inguinal ligament. Earlier also it was been asked about the attachment. Then the answer was iliacus. Iliacus actually is arising from the iliac fossa. Here, iliac fossa, that is the pelvic surface of the hip bone. From the iliac fossa, that is the concavity of the ilium on the pelvic surface of the hip bone. So that is iliac. So in case if it's asked about all the muscles having attachment to the iliac crest, and one of the choices is iliacus, so you can rule out iliacus. But right now here you're seeing that there's only one muscle that is blue in color, and you know the color coding: blue is for insertion and red is for origin. So red means all these muscles are taking origin from iliac crest. So which muscle has its origin above and insertion below? Means we're talking is about insertion. So in the image I just drawn, you have seen that external oblique abdominis is a muscle which arises from above. That means from the outer surface of the lower 8 ribs, and it descends down to insert on the iliac crest. So its origin is above and insertion is below. Rest all the other muscles, we've just seen in the diagram, they're taking origin from the iliac crest, so they have origin below and they will insert above onto the ribs or the vertebrae. Question number 11. Quadratus lumborum muscle. Which is the wrong statement? It fixes the last rib during inspiration. Unilateral action is it causes lateral flexion of the vertebral column. Bilateral action is it flexes the lumbar spine. It is supplied by ventral rami of T12 to L4 spinal nerves. Now to understand about this muscle quadratus lumborum, you know that this muscle is a muscle of posterior abdominal wall. So it arises from below and inserts above. The sites of origin about this muscle is, one is that it arises from the transverse process of L5 vertebrae, and there is this iliolumbar ligament like this. So it also arises from the iliolumbar ligament and also from the inner surface of the iliac crest at its posterior 1/3. This much. About the insertion thing, it is inserted onto the anterior surface of the transverse process of the upper 4 lumbar vertebrae on its lateral portion, because medially it's the origin of psoas major, you know that. And it also takes insertion here onto the medial half of the lower border of the 12th rib on its inner surface like this. So you've got to know about the origin and insertion. Now look about its muscle fibers. As you know, these muscle fibers will ascend up like this. This is how this muscle is. This muscle also forms the floor of many viscera, including the kidneys, sigmoid colon, ascending colon, descending colon, both the sides. So same pattern it will be on the opposite side as well. This is quadratus lumborum of both the sides. See the shape. This muscle is actually quadrangular in shape. That's why its name is quadratus lumborum. This muscle is innervated by the direct branches from the anterior primary rami of T12, L1, L2, L3 and L4. So the nerve supply is T12 to L4. Now think about its action. If this muscle contracts, like supposedly a person even sitting or having a pelvis fixed, so while inspiration actually it will withhold, it will fix the 12th rib down. So while inhalation or inspiration, your diaphragm can contract smoothly for more effective contraction of the diaphragm. Now think about unilateral contraction. If a muscle on one side contracts, obviously this is going to tilt the lumbar spine to that side, causing lateral flexion. Now you know that this lumbar spine is like this, and here you have is the sacrum. So the pattern of muscle was like this, remember? Because you have a lumbar lordosis, like anterior convexity of the lumbar spine. So very important to understand this is when this muscle contracts, so what will happen? It will actually help in aggravating this lordosis, and in that way it will help in extending the lumbar spine, or to make you sit up in an upright position on the chair. So its bilateral action helps to extend the lumbar spine. Quadratus lumborum, wrong statement. You got to know the answer is bilateral action. This is actually helping extension of the lumbar spine. Question number 12. Which is a paired plexus? Celiac plexus, aortic plexus, superior hypogastric plexus, inferior hypogastric plexus. Now this question is about the autonomic plexuses below the diaphragm. Just for your revision, remember that these plexuses are located along the abdominal aorta and its branches. From below the diaphragm, you have this medial arcuate ligament and then the lateral arcuate ligament like this. These are the ventral unpaired branches. These are the visceral splanchnopleuric branches. So these three branches, this is the celiac trunk. To supply blood to the structures derived from the foregut, this is superior mesenteric artery supplying structures derived from the midgut, and this is inferior mesenteric artery supplying blood to the structures derived from the hindgut. And you also know that there is this sympathetic beaded chain that descends down here from this medial arcuate ligament, which continues down on either side of the spine and reaches down at the level of coccyx to form this ganglion impar. This is the right crus of the diaphragm, and here it's the left crus of the diaphragm. So through these crus of the diaphragm, there are greater and lesser splanchnic nerves emerging out. The greatest splanchnic nerves are from T5 to T9, and you have lesser splanchnic nerve from T10 to T11. This is greater splanchnic nerve, and this is lesser splanchnic nerve. And of course, you also have a least splanchnic nerve, that is T12, least or renal splanchnic nerve. So these nerves, when they descend down, they actually, and there is the contribution from, there was phrenic nerve descending down. The right phrenic nerve was descending down from this vena cava opening, and the right and left vagi, they descend down through this esophageal opening. So you have right and left vagus, the 10th cranial nerves, as well as the right phrenic nerve. They participate here in an anastomosis and they form a plexus around here that includes two ganglion here on the sides of celiac trunk. So this plexus formed here, it has contributions from the L1 and L2 segments of this sympathetic chain as well, and that forms this celiac plexus. The celiac plexus diverges out along this different branches, like the plexus around the left gastric artery supplies the stomach, the plexus along the common hepatic artery supplies the liver. It diverges and reaches to the porta hepatis from hepatic plexus, then cystic plexus. Similarly, along the splenic artery, there will be a plexus surrounding spleen, so that is splenic plexus. So all the way, the different branches, they carry these nerve fibers. Similarly, this plexus descends down and surrounds to this superior mesenteric artery. So this plexus, which runs along the superior mesenteric artery, supplies autonomic fibers to the structures derived from the midgut. Now this plexus descends down further like this, and it forms a plexus along to this inferior mesenteric artery as well, and it continues down here further to form a plexus at below to this bifurcation of the aorta in its terminal branches. And this plexus also gets a contribution from the lower two L3 and L4 splanchnic nerves as well. This plexus is called superior hypogastric plexus. This one here is called superior mesenteric plexus. This is inferior mesenteric plexus, and the plexus between anterior to the abdominal aorta, this is called aortic plexus, also called as intermesenteric plexus. Now there's a plexus there in the true pelvis, here on the lateral wall of the pelvis, on the two sides of the rectum, on the two sides of the prostate or seminal vesicles, even in case of females, at the level of the cervix on the either sides, at the level of the fornixes of the vagina on either sides. So you find is a plexus here, and this plexus receives contributions from S2, S3 and S4 from both the sides, and these are called pelvic splanchnic nerves. And this is actually a parasympathetic contribution to this plexus called inferior hypogastric plexus, while the sympathetic contribution to this plexus is in continuation from this superior hypogastric plexus, and this branch which communicates the superior and inferior hypogastric plexus is called hypogastric nerve. So all the structures within the pelvis, including the parasympathetic innervation of the structures derived from the hindgut, as well as the structures, the viscera within the pelvis, they're all being innervated by the inferior hypogastric plexus. So inferior hypogastric plexus, you have seen here that this is a paired plexus. Rest all the plexuses you have seen in this diagram, they are all unpaired plexus and median plexus. So the question is, which is a paired plexus? So answer will be inferior hypogastric plexus is a paired plexus. Question number 13. Which of the following structure is derived from the mesonephros in male? Seminiferous tubules, rete testis, vasa efferentia, and epididymis. Getting to know what I'm drawing here, it's the embryo in a transverse section, the dorsal portion of the embryo. Here you find is the developing spine, and here you will find is the dorsal aorta, peritoneum. So make sure what I'm trying to explain is about the swelling on the two sides of the dorsal aorta. This dorsal aorta, there's a swelling that develops vertically along the length of the developing embryo from the cephalic to the caudal end, and this is called the nephrogenic cord. It's derived from intermediate mesoderm. To make it a little more clear for you, this swelling actually brings about these type of changes like this. This green color portion what I have drawn here is going to develop into nephrogenic cord, which actually will in vertical portion here I'm drawing is it's actually like this. Vertically it's like this, both the sides of the dorsal aorta. This has been divided into three parts. This is pronephros. This is along to the cervical and dorsal region. This is mesonephros along to the lower thoracic and lumbar region, and this is metanephros. This is along to the lower lumbar and sacral regions. So these are the two cords, nephrogenic cord extending from the cervical to the sacral region. Here in the middle you have this dorsal aorta. Then lateral to that you find is a swelling which encloses this duct, and this duct is called mesonephric duct. And even lateral to that there's another duct, and this duct is called paramesonephric duct. This paramesonephric duct is also called Mullerian duct, while this mesonephric duct is also called Wolffian duct. As a general point, let me tell you that mesonephric duct actually it's going to develop into the ejaculatory pathway, the tubular. Because there's less of space, I should summarize it here. Next time, sometime I'll teach you all it in detail. Tubular ejaculatory pathway of semen and tubular excretory pathway of urine in both male and females. So what will it derive into males? It will develop into epididymis, then vas deferens, seminal vesicles. Actually, seminal vesicles are just similar, just like evagination from vas deferens. So the same lining epithelium is there, and then ejaculatory ducts. All these structures you mentioned here, they derived from the mesonephric duct. Then in case of both male and female, there's a ureteric bud that arises from the lower portion of this mesonephric duct. So it develops into minor calycis, major calycis, then renal pelvis, ureter, and trigone part of urinary bladder, the epithelium covering the trigone part of the urinary bladder, as well as part of that prostatic urethra, as well as posteriorly, that also is being developed from this prostatic urethra that will evaginate and will form the inner zone of the prostate. This contributes to the prostate as well. While right now we're talking is about the structures derived. So now talking about structures derived from paramesonephric ducts. Mullerian duct. This actually participates in forming the female internal genital system that includes fallopian tubes, uterus, and upper portion of vagina that develops from paramesonephric duct. In males, of course, paramesonephric duct, the upper end will persist as the appendix of testis, that's called hydatid of Morgagni, and the lower end of the paramesonephric duct persists as the prostatic utricle, which is like supposed to be the homology of the uterus or vagina in males, that is prostatic utricle, the lower end of the remnant of paramesonephric duct in males. So now we'll be talking about the nephrogenic cord. So this nephrogenic cord you are seeing here on its medial side, this epithelium you're seeing on the medial side of the nephrogenic cord, this portion I've drawn it in pink color. This actually is going to develop into a genital ridge. Now let's zoom this image of one side. This is the yolk sac. This is the gut. This is the dorsal aorta. Now in this region, because I told you that initially the nephrons, the kidney, if you talk about the nephrons, they develop from pronephros in the very early stage of development. Then in later stages of embryogenic life, the kidney, the nephrons also develop from mesonephros. Later on, with the formation of the definitive kidney, it starts developing from the metanephros. So the adult human kidney is developed from the nephrons developed from the metanephros. However, it's said that the ontogeny repeats phylogeny. So in case of human embryo, because in the early stages of embryogenesis, pronephros is one which is forming the kidney, but still it's said that the cyclostomes, the fishes, they have the kidney being developed from pronephros, and the lower vertebrates or called anemniotes, they still have the kidney, functional kidney being formed from mesonephros. So that means the human kidney, during its course of development, keeps repeating its ancestral origin. That's called ontogeny repeats phylogeny. Now we are back to this development of the testis. So remember what I was saying is this epithelium, the thickening of epithelium, the peritoneum, coelomic epithelium that thickens here in this region, the medial side of this nephrogenic cord. Basically, we're talking is now of the mesonephros. This means the section which I've drawn is at the level of the upper lumbar region. So there, this actually what I've cut here is the green color thing. This portion is the mesonephros, not pronephros, not metanephros. This is mesonephros. So this coelomic epithelium, when it forms this genital ridge, it actually forms new cells dividing and approaching towards this mesonephros like this. And these are called sex cords. And mesonephros itself also, as I told you before, that it was forming the kidneys, means the nephrons. So they also have these tubules there. Mesonephros also has these tubules. In fact, this tubular formation will be present in pronephros, mesonephros, metanephros. But accordingly, during the stage of development, finally the kidney develops from metanephros. But in this region of the mesonephros, some of these mesonephric tubules, they persist and they will now participate in formation of the testis. So sex cord, actually, these sex cords later on they get canalized. So when they get canalized, they form the seminiferous tubules, and the cells surrounding to them, they will form the Sertoli cells as well as granuloscells. Then later on what happens, there was this mesenchymal cells surrounding, right? Mesenchymal tissues. These mesenchymal cells, they invaginate and they separate out this sex cord which were being formed from the epithelium, mesothelial epithelium, and they get separated. So that separation by these mesenchymal cells leads to formation of tunica albuginea. So that's how this Sertoli cells and all the seminiferous tubules, they all get encapsulated in a fibrous sac, that's tunica albuginea, formed by this mesenchymal cells. And these mesenchymal cells, they also get spread in between these sex cords like this. They start growing and proliferating in between these sex cords. Mesenchymal cells of the nephrogenic cord, they will form tunica albuginea, and of course they will also form the interstitial cells of Leydig's. in the testis, there is a mediastinum. It's called mediastinal testis. So that mediastinal septa is also formed by this proliferating mesenchymal cells. And don't forget one more thing about this seminiferous tubules which were being formed from these sex cords. They also cross to this, part of that seminiferous tubules remain here in the lobules of the testis, but part of them they cross the mediastinal testis and reach into, they actually form a plexus here. Let me draw in the pink color. So they form a plexus here, and the plexus is separated by this mediastinum formed by the mesenchymal cells. This is mediastinum, and which separates this meshwork of tubules separated by this mediastinum and this forming the rete testis. So seminiferous tubules, after crossing the mediastinum testis, they reach there in the medial portion of the testis where they form a plexus, and that's called rete testis. Now rete testis are also being formed by the canalization of the sex cords. So all of these colors I have used to mention the structures derived from different portions of this nephrogenic cords. So I hope you've understood about this origin of different types of cells. Now lastly, what remains is mesonephric tubules. These mesonephric tubules, they will form efferent ductules, which is also called as vasa efferentia. So vasa efferentia or the efferent ductules actually communicate the rete testis to the epididymis. And the blue color I had used in the first diagram. So remember, it's here, this is the mesonephric duct. It's here, there is the paramesonephric duct. So these light green colored thing which I've used is for the formation of vasa efferentia or efferent ductules, which communicate the rete testis to the epididymis, because epididymis will be formed from mesonephric ducts. I hope you've understood the answer by now. So which of the following structures derived from mesonephros in males? Seminiferous tubules, from canalization of sex cords. Rete testis also form canalization and then anastomotic network formed by the anastomosis of these canalized sex cords. And epididymis was being formed by mesonephric duct. Vasa efferentia is formed from the mesonephric tubules or mesonephros in males. The answer is vasa efferentia, which is also called as efferent ductules. Question number 14 is, all of the following cells are derived from the sex cords and the gonadal ridge except. This is a question related to the similar topic which I had explained before. So let's see the options here. Sertoli cells, interstitial cells, granulose cells, and spermatogonia. Here in the same image, the development of spermatogonia. So remember that spermatogonia, actually, this is not a very clear-cut, definitive research, but it is believed that the primary sex cells, which are the parent cells of the germ cells, means the spermatogonia, which are actually going to divide meiotically to form haploid cells. Those are called spermatozoans. This is like the primary sex cells or the spermatogonia. Similarly, don't confuse, in case of females, there will be oogonia. That's why I've mentioned is the sex cells. Though these sex cells actually, they migrate along the body wall and will reach there and will enter into this sex cords from the medial portion of these nephrogenic cords, or it might also reach from the ventral mesentery and will through the dorsal mesentery and can also reach from there. So these spermatogonia are the migratory cells. So they develop along the primitive yolk sac. Actually, it's a secondary yolk sac. So from around to the secondary yolk sac, the spermatogonia actually develop and then they migrate along to the body wall or through the mesentery, both ventral and dorsal mesentery, and to reach, and they get relocated within this or intermingled between the cells of the sex cords. That's how this spermatogonia is not derived from the nephrogenic cord. Remember that. So Sertoli cells, derived from the sex cords, interstitial cells derived from the mesenchymal cells which migrate between the sex cords, even the granulose cells formed by the sex cords. Finally, it's the spermatogonia. Remember, these are the migratory cells derived along the primitive yolk sac, that is the secondary yolk sac. Question number 15. The urogenital system is derived from paraxial mesoderm, intermediate mesoderm, lateral plate mesoderm, primitive urogenital sinus. So just now in my previous two questions, I had shown you that intermediate septum was developing into a nephrogenic cord. The medial portion was divided into pronephros, mesonephros, metanephros, and from there, the metanephros was giving rise to the formation of the kidneys, as well as the genital ridge formed medially from the coelomic epithelium into sex cord. They were forming the part of the testis. Then lateral to that was the mesonephric duct. Mesonephric duct was forming the structures of the ejaculatory pathway, epididymis, vas deferens, seminal vesicles, and the ejaculatory ducts, while the mesonephric tubules were forming the vasa efferentia or the efferent ductules. And part of this mesonephric duct was also contributing to the formation of the drainage apparatus of the urine, minor callus, major callus, renal pelvis, ureter, bladder, the lining epithelium of bladder covering the trigone, everything. Paramesonephric ducts, they're also part of this intermediate mesoderm. They were forming the female genital system, the fallopian tubes, uterus, and upper portion of the vagina. Okay, then talking about the primitive urogenital sinus. This is a part of the cloaca, the anterior portion. Cloaca was being divided by the urorectal septum. This is urorectal septum into this primitive urogenital sinus, and this was going to be formed as the primitive rectum. Primitive urogenital sinus will now be divided into upper portion as the vesico-urethral canal, and this is the definitive urogenital sinus. So vesico-urethral canal will now be forming the urinary bladder and the primitive urethra, which actually will form the prostatic urethra in males and the female urethra. The definitive urogenital sinus will form the pelvic and phallic portion of the male urethra. So what have you concluded? That both intermediate mesoderm and primitive urogenital sinus, they required for the formation of the urogenital system. So 2 and 4 both. So the answer will be C. Question number 16. Developmentally, hymen is endodermal in origin, mesodermal in origin, ectodermal in origin, partly endodermal, partly ectodermal in origin. Now for this you need to understand the development of vagina as well as the hymen ducts. Later on this fuses to form the uterovaginal canal like this, which after canalization forms this type of cavity. And down below here it's this urogenital sinus. So with this uterovaginal canal, which is mesodermal in origin, mesodermal because it's derived from paramesonephric duct, also called as Wolffian duct. Urogenital sinus is endodermal. This is uterovaginal canal after being canalized. So when this approaches towards this urogenital sinus, from the lining of this primitive urogenital sinus, there is this sinovaginal bulb. These are the endodermal thickenings proliferated from the wall of the urogenital sinus. This is sinovaginal bulb. Now together with this sinovaginal bulb, I am drawing it this much portion here to zoom it out. So this is the uterovaginal canal, and this is the urogenital sinus, and this is the sinovaginal bulb. So the two sinovaginal bulb, they actually fuse to form a solid plate here. So later on what you find is this is the urogenital sinus. This is the sinovaginal bulb, which has proliferated to form a solid plate, vaginal plate, and from above, it's this uterovaginal canal protruding into this. Now, this uterovaginal canal also proliferates within this vaginal plate for the upper one third portion. That is this, this is mesodermal, this is endodermal, this is the solid vaginal plate. Later on, this vaginal plate gets canalized. So, in the end, what you find is this uterovaginal canal itself gets canalized and it opens here at this internal os to form this cervix. As I told you before, that part of this mesodermal line thickening from the uterovaginal canal, it extends in upper one third of the vagina, but this vaginal plate that continues to form the lining of the vagina in the lower two third, and where it was joining this vaginal plate, where it was joining this fundus of this urogenital sinus, here also it gets perforated so as to form an opening. Now what you conclude here, that this is the development of vagina. Upper one third of vagina is lined by mesoderm and the lower two third of the vagina is lined by endoderm. I think this was a short question also in your subjective portion of your question paper. Section C, question number 2A. It was about this only, the development of vagina. What you're seeing here, this is called hymen. So this vaginal plate which joins this urogenital sinus, it was initially imperforated, but later on gets perforated, and there it's the formation of opening of vagina through the hymen. So the hymen you see is completely formed by the urogenital sinus. So that means hymen is completely endodermal in origin. The question here was development of hymen is. Answer, you've got it now. It is only endodermal in origin. Question number 17 is, which lymphoid organ has no afferent lymphatics? Lymph node, spleen, thymus, tonsil. The answer here is tonsil. Now, when you mention tonsil without any prefix or suffix, we assume we are talking it is about the palatine tonsils. If you're talking is about the oral aperture, then what you find, there is tonsil protruding out from the two sides, and that tonsil is actually covered by anterior and a posterior pillar. Anterior is palatoglossus and posterior is formed by palatopharyngeus, the two muscles. Between the two tonsillar pillars, you find is tonsil protruding out like this. In case of tonsillitis, they protrude out more. Basically, we are concerned about talking about afferent lymphatics. So tonsils, you see, first of all, the tonsils, they are partly encapsulated organs. They have these crypts. These are called tonsillar crypts. And this lining epithelium of this portion of the tonsil, let's say this is tonsil of the right side, one tonsil. So the portion of the tonsil which is protruding out in the oral cavity, this portion will be lined by an epithelium, and there is nothing new about it. The same epithelium which lines the oral cavity, and that is stratified squamous non-keratinized epithelium. Another thing is identifying is they have crypts, tonsillar crypts, and one of the crypt is long enough, and that is called crypta magna. So you can presume that these crypts are actually, because it's facing the oral cavity, right? So all of the food and whatever you're taking in your mouth, they itself will be pushed into these crypts. The food particles or whatever substance there is, the liquid also, they will be pushed here into the crypts. So, and that crypts will be taken up, the substances in the crypts will be taken up as just like an afferent lymphatics for these tonsils. So there is no afferent lymphatics in the tonsils. This is an important point about tonsils. Another very important point about the tonsil is, remember that this tonsil is not completely encapsulated. Only the portion facing the oral cavity is capsulated. And the third point about this is the lining epithelium, which will help you identify, that is stratified, squamous, non-keratinized, and the crypts also. These are few important points about the tonsils. No doubt you will have these lymphoid aggregates here. Lymph nodules will be present in this. In case if I ask you right now, which lymphoid organ you will not find lymphoid aggregates? Lymph node, thymus, spleen, tonsil. So remember that thymus has homogeneously spreaded lymphocytes. You don't have lymph nodules in the thymus. Question number 18 is Crescent of Guanuzzi is a microscopic feature seen in parotid salivary gland, submandibular salivary gland, sublingual salivary gland, or the lingual salivary glands. Now, to understand this, you need to know the histology of salivary glands, the large salivary glands, parotid, submandibular, sublingual, right? So they are basically like compound tubuloacinar glands. They have ducts. That duct actually then diverges and ramifies into several. Just like you remember the pattern of those bronchial tree, bronchial apparatus. Similarly, is the pattern here also. So they keep on dividing like this to form different tubules. It's like this. This is how a salivary gland is being formed. The duct actually branch and rebranch like this. So this is how it all ramifies like this. Anyways, so at the ends of these you find is like, the acini, and these acini, it may be mucus secreting acini or maybe serous secreting acini. Well, I need not draw all of them. So what we're concerned about here is talking about the acini. So let's see that this is an acini of a mucous salivary gland, and this will be an acini of a serous salivary gland. So difference is that in the mucous acini you find is the basal nucleus and larger cells with the mucus secreting acini towards the apices, but those will not take good stain, because they are neutral substances. Unlike to this serous secreting acini, they have a central nucleus, and they will have the protein synthesizing apparatus, that is the rough endoplasmic reticulum, ribosomes. They will all be basal to the nucleus. What will be towards the what will be towards the apices of these cells? Towards the apical surface, there will be vesicles containing zymogen granules. So because all these proteinaceous structures, these serous containing acini, they take good stain, the violet stain. So in a histological slide, if it's a serous salivary gland, that will be darkly stained with a purple or violet dye. In case of mucous acini, you will see pale, you won't find a good stain there, like in the case of goblet cells. Now, in case of, we're talking is about the mixed salivary gland. In case of mixed salivary gland, not all, but some acini you will find is like this. You have this mucus secreting acini here. And this mucus secreting acini, I've already told you, it's like this with the basal nuclei. But there will be some acini which will override to this, like this. This acini is overriding to this acini like this, and this is a serous acini. Components of the serous acini, I have told you, you can find a nucleus there in all of them, right? They will be taking good of stain. So this is how it is. Now if you take a transverse section of this acini, you will find it appears like this. A central acini with large cells which are actually mucus secreting cells, but it will be surrounded by another acini like this. Such an acini surrounding an acini in a crescentric way, because in a section you find is in like a crescent. Mucus, of course, will be drained out like this. And what about the secretions of this serous acini? Serous secretions actually are drained through this intercellular canaliculi of this mucous cells, and then it also drains through the same ductules. That is the pattern of drainage. So remember that the serous acini encapsulate the mucus secreting acini in case of mixed type of salivary glands. So this is a feature of mixed salivary gland, and this you will find in submandibular salivary gland. Mainly serous salivary gland, the example is parotid, and mainly mucous salivary gland, example is sublingual salivary glands. These crescents, they are called Crescent of Guanuzzi, or they're also called Demilune of Heidenhains. They are feature of mixed salivary gland, and that example of mixed salivary gland is submandibular salivary gland. So the answer here is Crescent of Guanuzzi. Answer will be submandibular salivary glands. Next question number 19 is about the coiled tubular gastric glands are seen in the mucosa of which part of the stomach? Cardiac part, fundus, body, or pylorus? This what I'm drawing is the mucosa. Consider this to be the mucosa. So here you finding is tubular gastric glands in the cardiac portion, and in the body also you will find the tubular gastric glands. They have a neck, they have a body, they have a fundus. Consider this only the mucosal layer I have drawn. Now in this portion, the pyloric portion, you find two types of speciality, that these glands may be branched or may be coiled like this. They may be coiled, they may be branched. Branched is like this, branched or coiled. The feature of pylorus gastric glands, fundus and body same, simple tubular full thickness of mucosa. Means in the fundus, as I've drawn, in the fundus and body you will find these simple tubular glands, they're traversing the entire thickness, the full thickness of the mucosa. Unlike in pylorus, you can say half the thickness. Pylorus, you will find these glands reaching only to the half the thickness of mucosa. And in case of cardiac part, of course, you will find simple tubular, but they will be only reaching to the half thickness of mucosa. Long gastric glands, which are extending throughout the thickness of the mucosa, they will be found in fundus and body. But remember, in the case of pylorus, branched or the coiled tubular glands, the features of pyloric region of the stomach. Question number 20 is Hassel corpuscles are characteristic features of thymus, spleen, lymph node, or palatine tonsil. It's a hallmark feature of thymus. Now thymus, when I'm drawing a thymus like this, let's say it's a thymus, so it will have a capsule, of course, and the capsule will send its septa here inside. But important about this septa is that these septa do not divide the thymus into lobules completely. It doesn't reaches into the medulla. Thymic cells, they have this cortex and medulla like this, differentiated cortex and medulla like this. The important thing about thymus, I already told you that you don't find lymphoid nodules. You don't find aggregates of lymphoid follicles in the cortex of the thymus. You find only the densely homogeneously placed lymphocytes here in the thymus, not like nodules here. Unlike the lymph node, spleen, palatine tonsil, there you find lymphoid nodules. Here it's the homogeneously spreaded lymphocytes. You will of course find lymphocytes here in medulla also. This is the portion which is the medulla of the thymus. you will have blood vessels. Then important thing is that few of these cells here, lymphocytes of the thymus actually, with age, they start losing their the autoimmune regulatory expression, the ability to perform their work. So what happens is they start collecting here inside in the thymus medulla, granular cells, and then the epithelial cells, they come in around. These are the epithelioid cells which come and arrange surrounding to this lying out granule cells, which actually is a thymic cell which has lost its ability to express those autoimmune regulatory expression. So such type of corpuscles, Hassel corpuscles, they will be found here in the medulla of the thymus. So these are called Hassel corpuscles and is a feature of thymus seen in the medulla of thymus. Now talking about section B, it's describe the kidney in the following headings. This was a long question, a structured long essay type question. So you had to describe the gross structure of the kidney, visceral and peritoneal relations of both the kidneys, arterial supply, both intra-renal and extra-renal portion of the arterial supply of kidney, renal colic, and the kidney transplant. There were short questions, 5 marks each. Describe briefly the layers of the scalp and formation of the black eye. Then blood supply and nerve supply of dura mater. Then tributaries of the cavernous sinus. Short notes, 5 marks each. Cellular architecture of nervous tissue. This was to be described. Types of neurons and the types of neuroglia, as well as the microglial cells. Then epiploic foramen, histology of small intestine. Section C again was 40 marks. The 10 marks long essay type question was about describe extra hepatic biliary apparatus under following headings. It described the gross structure of this extra hepatic biliary apparatus, then relations of the common bile duct, supraduodenal, retroduodenal, infraduodenal, remember, and then relations of the gallbladder, and referred pain due to cholecystitis. There was an MCQ on this, and Courvoisier's law also has to be mentioned here. Courvoisier's law states that if there is a dilatation of the gallbladder, then it's due to any extra biliary cause, means there is some pressure, mechanical pressure, or any such cause which is compressing or obstructing the flow of bile from outside, like carcinoma head of pancreas. So that means the dilatation or the turgidity of the gallbladder is not through the intrinsic causes, like the gallstones within the gallbladder are not a cause for the dilatation of the gallbladder. 5 marks question was about describe briefly development of vagina, development of interatrial septum, and histology of liver. All of them are very important questions. Write short notes, again 5 marks each. Blood supply of stomach, psoas major muscle, abdominal aorta and its branches. So that was